Hello, everyone. Thank you so much for joining us for this webinar today, where we will learn about best practices for ICU care of COVID-19 patients in the United States. We have today a group of experts who are frontline workers from different hospitals within the US, and they will share with us their knowledge and experience about ICU care of COVID-19 patients. First of all, please let me introduce you to Dr. Nareen Ahmed. She's originally from Philadelphia. She attended Drexel Medical School and completed her residency at the University of Illinois in Chicago, where she also completed her MPH and served as chief resident. She then completed her fellowship in pulmonary and critical care at NYU Bellevue, which is also where she launched her global health career, funding the Bangladesh Ultrasound Initiative, which is a training program for critical care physicians in Dhaka, Bangladesh. Since then, she's been involved in several bedside ultrasound training programs, and she is currently the head ultrasound of MedGlobal and of another organization called Bridge to Health, giving her the opportunity to share her knowledge on bedside ultrasound in low-resource countries such as Sierra Leone, Yemen, Pakistan, Uganda, Kenya, and Tanzania. She also helped train the entire Penn Division of Critical Ultrasound program, which is an ultrasound training program for all incoming critical care fellows in the area, which was launched in August 2018. Welcome, Dr. Ahmed, and thank you so much for joining us. Second, we have Dr. Ross Hoffman. He's a native from Norfolk, Virginia. He received his bachelor's degree in international relations from the University of Virginia. After a short career in an investment brokerage firm in New York City, he changed careers and pursued a medical degree in the University of Queensland, Brisbane, Australia. He completed his residency in internal medicine at the Ochsner Clinic in New Orleans, Louisiana, where he remained to complete his fellowship in pulmonary and critical care medicine at the Louisiana State University. He currently practices as an associate in Asheville Pulmonary and Critical Care Associates in Asheville, North Carolina. We also have with us, shortly will join us, Dr. Asim Elahi. He completed his medical residency in internal medicine and also served as chief resident at the Brody School of Medicine at East Carolina University in North Carolina. He completed then his pulmonary care and sleep medicine fellowship at the University of Tennessee, and he is currently an attending at Atrium Health in Charlotte, North Carolina, where he works as a pulmonary and critical care and sleep medicine specialist, and he is also the pulmonary lead for lung cancer screening. His clinical interests are advanced bronchoscopy, thoracic malignancies, and pulmonary embolism. He has also done several humanitarian trips with MedGlobal as well and other organizations to Puerto Rico, Gaza, Bangladesh, Sierra Leone, and Jordan. And last but not least, we also will be joining us in this webinar the MedGlobal president, Dr. Zaher Salul. He is a pulmonary and critical care physician. He has done he co-founded MedGlobal, and under his leadership, MedGlobal partnered with local communities to build resilience and in the face of diseases and wars using technology and innovation and focusing on the training of the local healthcare providers. He has received several awards, such as the Chicagoan of the Year in 2016 for risking his life in medical missions in Aleppo. The Heroes Among Us Award by the American Red Cross in 2017, and the UNICEF Chicago Humanitarian Award in 2017. And lastly, he received the Robert Kirshner Award for Global Activism by Heartland Alliance, among other awards and recognitions. With him also, MedGlobal has gone to 14 different countries, so we are lucky to have him as well join us in this webinar. So Nareen, thank you so much for leading this webinar right now, today. The floor is yours.
Sure, great. Thanks so much for having me. So, the purpose of this conversation is really, as we've seen with COVID-19 across the country, so many of us have learned from each other about best practices as we learn more about these patients. So this really is meant to be a conversation and kind of go through some really high yield topics and learn from each other about our experiences with COVID in our respective areas. So I'll start with just a first, big question from your experience, and I'll start with Dr. Hoffman. From your experience, what would you say are the main differences and the unique issues that surfaced in your experience with managing COVID patients in the ICU compared to your other critically ill patients prior to this pandemic?
Thank you, Noreen and Denise. Great to be here. This disease has been, and pandemic has been so overwhelming based on what most of us have known, and even the senior attendings that we've all had in fellowship and beyond have never really encountered this kind of crisis. In terms of what is unique, I think that the volume of patients in many centers has been, again, overwhelming. This, of course, puts a direct strain on resources, really in every sense. Certainly the doctors, the nurses, the respiratory therapists, and everyone who contributes to patient care, but also on administrators who are charged with making sure there's adequate testing. Certainly I know in our area it took us quite a while to get testing to where it needed to be. In the ICU itself, certainly the myriad manifestations of respiratory failure are well known. The elevated work of breathing that many COVID patients have, the happy hypoxemia, where even with oxygen saturations in the low 80s, sometimes they're sitting in bed pleasantly looking at you, eating, talking on their phone. Ventilator support has been a challenge. Different phenotypes proposed, coming from, especially from Italy, Dr. Gattoni. The bimodal illness, many patients getting worse, getting better, and then coming back to the ICU a few days after their step down with what seems like a recurrent respiratory failure. And in that case, you never know if it's secondary infection or return of COVID respiratory failure. What to do with patients who have been on the ventilators for 2 or 3 weeks. Certainly my colleagues in New Orleans, where I did all of my training, sometimes having patients still on 60% FiO2 and 16 of PEEP, and whether that kind of patient can undergo tracheostomy placement with the idea that they may still improve in time. Whether to integrate ECMO as a treatment modality at the centers that have that available. And then some of the issues relating not necessarily to care, but to the people who provide it. The staff, exposures, having enough PPE, making sure that you concentrate procedures often into one proceduralist rather than having 3 different people do the intubation, the arterial line, the central line, dialysis catheter when needed. The mental health of staff. This has been a tremendous strain on the people who provide care. And then beyond that, for families, it's been terrible for families, many of whom have not been able to visit unless their loved ones are actively dying. Having seen and had so many conversations over the phone when you really can't describe to the family what their loved one looks like and how many machines they're hooked up to, it can be very trying. Palliative care certainly has been, had an invaluable role in treating these patients. Though for some families, they have a hard time grasping just how sick their loved ones are, having seen them relatively healthy only a few days before. Those are just some of the issues.
Yeah, so I mean, I think you hit on a lot of really big categories, such as hospital, the hospital level changes that we've seen, the clinical changes that we've seen in management, and then just the emotional side of it, the human side of it. And so I'll sort of, that's kind of how I was thinking about the three big categories and how to think about our experiences and the main, those main big differences. I'll now ask Dr. Elahi Azim to kind of comment on the same question and give us a little bit about what you've experienced and some of the differences.
I totally agree with that perspective. Initially there was just so much unknown about the disease itself, how to best prepare for it. There was so much angst over whether or not we were prepared with adequate protective gear. What was the correct protective gear? There were so many discussions about that revolved around all of these concepts. And I think, when we're talking about the human aspect of all of this, it's in this disease, there was so much more emphasis now on not only the patient human aspect of it, but even the caretaker side of it, with the physicians and the nurses and the nurse practitioners and the PAs and the RTs and everyone that comes in touch with the patients, the cleaning staff, the techs that come in to do diagnostics. So that was a sort of a new aspect of the care in this 2020 year that evolved pretty dramatically. I definitely agree with so much of what Dr. Hoffman's mentioned with how things evolved. I think he summarized it very accurately.
Yeah, and I think, some of those things, when we talk about it, it can feel so disheartening because I think this was such a big emotional trauma for so many of us. But I think one of the biggest positive things I've seen come out of this, as well as you guys both describe your experiences, is the amount of innovation, the collaboration that has happened across disciplines, seeing our surgical colleagues come and help, people that aren't doing medical critical care that are coming to help with shift work and things like that, really seeing nurses and physicians band together to support each other. Classically, we're not a very emotionally transparent group of people. We compartmentalize a lot, but I think this is one of those scenarios. It's really hard to do that for many of us, and to really rely on each other, talk about those kinds of things, I think became a really big, important part of this pandemic that came out that was maybe a positive thing for us all, to really talk more about what we're experiencing, things like that. So I'll on that note, I'll kind of transition into the next question, which is sort of a segue from the first, which, based on all of the experiences that you've had, how has your management of COVID patients really changed over the last 3 months?
Is that one for me, Noreen?
Or
Yes. Well, what we're doing now versus what we were doing 3 months ago, it starts at the beginning. So the first thing is that we noticed as critical care doctors being called down the emergency room 3 months ago that our level of suspicion wasn't high enough. It's wonderful, or I suppose very clear anyway, if a patient presents with several days of fever, shortness of breath, dry cough, all of the typical symptoms, or if they present with the GI symptoms. But there are many heart failure exacerbations, COPD exacerbations, strokes that can sort of overlie this disease. And so, ideally you're testing widely, and in our group, we agreed that the question was not, do we have a reason to test, but do we have a reason not to test? And we started picking up the disease a lot more once we took that approach. Another thing is do the basics well. There have been swirling ideas about what specialized therapies may work, and for everywhere from the New England Journal to our president, everybody's got an opinion about things that should be tried. Most of these therapies don't have good evidence. And even if they have some evidence, we don't know if they'll work for COVID patients. So getting tied up in those sort of more peripheral issues you can sort of lose your focus. Doing the basics well is very important. Making sure that you're proning patients, following the ARDSNet protocol, unless there's a good reason not to do so. Another thing that we're doing a lot more is having patients self-prone. So for those patients who are not mechanically ventilated, getting them on their bellies. I've only had 1 or 2 patients tell me that they didn't breathe better after a little while, once they can sort of settle their nerves and get comfortable. We were, along with a lot of other centers, supporting early intubation 3 months ago. Now we actually try to let the patients go longer without intubating them if we can avoid it. Let them do their own work of breathing, looking out for evidence of end organ failure or airway insecurity as reasons to intubate, instead of just being sort of shocked by the numbers that we've seen on blood gases and labs. A couple other things, procedures, having not just specialists like anesthesiologists or surgeons, but also having specialized teams. So at our main hospital, there is one anesthesia team that does all the intubations for COVID patients, and they're on call. There's 3 different shifts, 8 hours each. That has minimized risk for a great many of our providers and had better outcomes for the patients themselves. Reducing aerosolizing procedures has been also a big thing. Not every patient needs duo nebs every 6 hours. A lot of them can get a metered dose inhaler. In many other cases, we can, it's actually helped us wean oxygen support for a lot of our patients to get them off of high flow and vapotherms and devices like that. And then another thing to mention, now versus 3 months ago, we are much more careful about conserving our consults. So it used to be COVID patients coming in where the creatinine went from 1 to 1.2. There might be a renal consult. I think infectious diseases was consulted on virtually every one of these patients for the first several weeks. And we've learned to conserve our consults. So certainly for ID and for nephrology, but also for cardiology. Not every COVID patient with a minor troponin leak needs a cardiology consult. And then also palliative care. We actually have consulted them more over weeks and months. But certainly we've stopped consulting them in cases where the patients are dying quickly and where really it's not a very wise choice of resources.
So I think that's an incredible response. I would say it very much resonates with what happened at our hospital as well in Philadelphia at Penn. Azim, I'd love to hear a little bit about how things evolved for you and how you and your institution were able to make those changes, where you received your information, how you collaborated, and how you made those decisions that were probably pretty similar. And please add anything.
Absolutely. You know, it's I certainly haven't been in practice as long as some of you guys have, but I'll tell you, one of the reasons why I went into critical care was because I just loved turning a chaotic situation into something organized or systematic. And I found it so interesting how when I began taking care of COVID patients, how much doubt there was in my mind about if what I was doing was right. I found myself second guessing myself so much because the more you read online with the experiences from Italy and the experiences from Wuhan and Korea, the more things varied. And it made me so doubtful at times about whether or not I was doing the right thing. Was I making the right decision to intubate now? Why, you know, these patients that were coming from the step down units to the ICU, should I have accepted them sooner? You know, can I keep them on Optiflow or Vapotherm or NIPPV for 12 hours or 24 hours or 2 days? These are all things that's evolved so much in the first month, let alone over the past 3 months about, you know, how to manage these patients. This is going to be funny, but if we go back 3 months, we were talking about ACE inhibitors and NSAIDs. Do I stop those medications on our patients? Now it's like way down in the list of our things to do for these patients. You know, there has been so much evolution in the care in these patients. And just like you said at the beginning, so much innovation about how we manage this. Just like Dr. Hoffman mentioned, we do have a specialized team. We were minimizing exposures. So if the patient ultimately did require endotracheal intubation, we had the anesthesia team come in. That process was streamlined, so they were placing the arterial line and the central line at that same moment, so that we could get that all done. I was fortunate. I'm at an institution where we are heavy with technology. We had access to virtual care, so every room is equipped with a camera. I was able to limit my exposure directly to these patients. And not only that, but expand my access to a more diverse range of patients, because I was able to be centralized and able to take care of more patients at any one time without sort of increasing my exposure risk. And so I found that to be a particular benefit. But listen, it took my first patient death to realize there were a lot of things we were doing wrong. It took my first patient death to realize how much of an impact this is going to have and already had on families and the patient themselves. To die alone in a room was so traumatic, obviously for the whole team taking care of the patient and for the family. And so we had to evolve very rapidly on figuring out, hey, we need to come up with a way to allow our patients and families to interact together, to make sure that we were getting updates to family members as well as we were supposed to have been doing prior to this whole pandemic. And so there was quite a bit of evolution along that way. You know, the initial discussions about how to manage these patients, that certainly evolved. I thought it was such a humbling experience to realize that I did not know it all, and that I did need to rely on my colleagues and the experts around the globe, really, in this situation, to keep up to date on what was happening, and literally was changing week to week.
Yeah, I would agree. Very humbling experiences that we've all had. So it looks like Dr. Zahir Soul has joined the call. So I'm going to defer the moderating responsibilities over to him. Very happy to have you.
Well, thank you very much, Nahreen. Thank you, Dr. Hoffman and Azim. Good to be with you. Thank you, Denise, for arranging this. And this is very important topic and dear to my heart, and everyone's in the medical field nowadays, especially that we are in the midst of this pandemic and it will not go away. I think some people may have a sense that numbers are going down. Okay, we don't have to worry about this, but actually we have to worry about this because of the unique situation of the virus, because of the fact that this virus is very smart. I mean, I said to many of my colleagues that this virus, the new novel coronavirus, has learned from other viruses how to survive. So it is very infectious and it attacks the body in different forms. And we are still learning how to deal with it. And probably what we are doing right now will change completely a few months from now, because what we are doing right now is not based on evidence-based medicine. We always, try to base our practices on evidence-based. There's not much evidence-based. Most of what we do in my hospital in Chicago, Christ Advocate Medical Center, is based on the earliest Chinese studies, actually, that were done in Wuhan, and nothing since then. That's also something that we have to worry about. I'm one of the victims, actually, of COVID. I'm a physician that was infected with COVID, like many of my colleagues and nurses. Fortunately, I did not have to be admitted to the hospital. I did not have respiratory failure or much respiratory symptoms, but it was really severe symptoms for 3 weeks. Still did not recover completely. And I think this is an area that healthcare workers have to address. How can we prevent ourselves from getting infected? The proper use of PPEs. If you have shortage of PPEs, yesterday we had a colleague, I was talking with a colleague from Bangladesh, who's telling me that many physicians in Bangladesh are dying and getting infected because of the shortage of PPEs, because of improper use of PPEs and the lack of infectious control measures in many hospitals in Bangladesh, and of course other developing countries. So this is an area that we have really to focus on. So the question now would be, I'm going to ask a few questions and try to address them myself, is most of the problem that's related to COVID-19 is respiratory problems in the hospital, at least initially. Patients come with severe hypoxemia, and it's amazing how they tolerate severe hypoxemia, SpO2 of 50% or 60%, and you see the patient awake and not in distress, looking at their Facebook when they come to the emergency room. But what is the difference or the major differences between respiratory failure, hypoxemic respiratory failure related to COVID compared to other infections or diseases that cause respiratory failure from your experience? Maybe you can start with Dr. Hoffman, then Nahreen, then Azim.
Well, that's a great question, Dr. Zalul. And I think that we're still trying to answer it. One of the real debates has been the different phenotypes of patient in respiratory failure from COVID, and whether or not we should be using the ARDSNet protocol for most of them, or if there's something better. There are doctors in Italy and Germany who have posited that these patients don't behave the same way on the ventilator. And a lot of that relates to elastance and whether preserved elastance in this disease means that the pathophysiology is different and should be treated differently. Normally in ARDS, you have a loss of compliance. You have the development of baby lung, as it's called, and you need to be careful. You need to try to keep the healthy lung that you've got, re-recruit the unhealthy lung through a number of treatments, whether it's volume reduction or antibiotics. In this disease, there's a theory, especially with the low PEEP, normal elastance phenotype, that a high PEEP will actually be injurious to the lung. And much as we used to do before the ARDSNet protocol came into vogue in critical care medicine, that you will blow out lung if you have them on high PEEP. Of course, that's a great idea, but when you're looking at blood gases with PO2s in the 40s on 80%, 90% FiO2, it's hard to accept that you don't need to dial up the PEEP in order to get better oxygenation. I think this really is going to be something that we figure out over time. I will say that for our non-intubated patients, we generally have stopped intubating them unless their work of breathing becomes unsustainable. They lose the security of their airway, or they become so encephalopathic that it just seems impossible not to intubate them. So patients, even with SATs, that are averaging low 80s, we are happy to let them sit in bed and do their thing, maybe self-prone, as long as they're able to be appropriate mentally, and they're not developing end organ damage from their hypoxemia.
So how about Nahreen? I mean, what are the things that you've learned about managing these patients with severe respiratory failure? And, I put an x-ray of a patient who looks like he has whiteout. I don't know if you're seeing it on the screen. This is a patient of mine who was intubated. And you can see also a big access for ECMO line. We're fortunate in my hospital that we have ECMO. I think we've done 50% of all ECMOs on these patients in the world in my hospital. But I mean, how did your learning on managing these patients who have the phenotype L that Ras has mentioned, low lung weight, low PEEP, low elastance, compared to the phenotype H, high lung weight because of the more inflammations, typical ARDS, basically high elastance and high requiring higher PEEP. How do you differentiate between both? How do you manage both?
Yeah, so I think that's a really tough question because, when Gattinoni first released his paper, it initially, it was widely accepted at first. And then I think more and more as people looked into where the data was coming from, as well as concurrent data that was coming out at the same time, there was a lot of controversy on whether or not his statement was accurate, whether or not that statement was accurate. And a lot of the data that we have found, and this is to sort of answer that question in a long way is a lot of this is coming from data as it's coming out, pre-printed publications, information before things are being validated properly. So I think it was really hard to see that and say, okay, this can apply to every patient, right? I think what really changed in my practice is to really pay attention even more so than usual to the hemodynamic information and the respiratory mechanics information that we get from the ventilator. What's the compliance when the patient is intubated? What are our driving pressures? What are our peaks and plateaus? And plateaus are mostly what we really focus on, right? And how does that change that personalized ventilator management? Because I think that's what really changed for me. To, in the beginning, we would have these severe ARDS patients, everybody follows a particular algorithm. But now I feel that all of these patients kind of fall in a different respiratory mechanic spectrum. And because of that, really paying attention to the numbers and the feedback we get back from the machine really helps personalize what we're doing for the patient. So for instance, somebody with a generally preserved compliance who's maybe very desynchronous with the ventilator, I might be more inclined to say, okay, let me liberalize the tidal volume a little bit because maybe it's not as injurious. We know that the range for low stretch is 6 to 8. And so maybe that's somebody who can tolerate that and we can minimize the sedation. And really balancing all of these things together as a whole was probably what changed the most for me, and recognizing that the COVID patients, especially those with relatively preserved compliance, had extremely high minute ventilations, which were forcing us to use incredibly large amounts of sedation, which came with a lot of problems. So I think in looking at this unilaterally as, okay, we have to just put them into a phenotype category and letting that drive the boat, I think is really challenging and limits us to what we can do. I think each patient kind of comes in with a different picture. The LH phenotype theory was really that in the early phase, patients have that preserved compliance, and in the later phase, maybe that goes away. Some data that came out of Seattle and I believe Boston kind of negated that this was in a time when they were intubating early on as well, and noticing that our compliance numbers were lower, relatively preserved, I guess you could say, but still they were lower than normal. So hard to say normal compliance, but the data being somewhat discrepant, I think, is what bothers me the most, is that we just don't know so much. That's what's really evident to me. And I think, as Ross really mentioned, doing the things we already know and doing them well, as in managing our ARDS patients and recognizing changes in their compliance and how that changes our vent management. I think that's really what drove my practice later on. In the beginning, I really wanted to have some algorithm that I could follow. And the more and more I treated these patients, the more I realized there is no algorithm. There is no real algorithm that fits every patient.
What do you think?
What's interesting, Dr. if I may just add, I don't think I've used recruitment maneuvers more so in the last 6 weeks as I had, the last year taking care of patients. I'm at a facility where we did not have, direct access to ECMO. We had to transfer patients to the main center for ECMO, and it's so difficult to do, obviously, on patients unless we have a team here to cannulate the patient at our center. And with COVID era, that became an added huge obstacle. And so it's just interesting that how the recruitment maneuvers and some of the sort of ancillary things of making sure you're doing what you do well have kind of factored in because of not having access to something beyond what we've traditionally been able to offer. I'm certainly curious to hear about what your experience has been with ECMO outcomes in these patients that you guys have had such a volume.
Yeah, the one other thing I wanted to add was because you just triggered my thought on some of the interventions that we're doing or changing a little bit based on these patients. I think one of the other really big things that changed in my practice is the comfortability with prolonged proning. In the beginning, I thought, what, all the papers say we prone for 16 hours and we flip them. There's that, that equation that we use. And more I started noticing that patients were doing better after proning for maybe 24 hours. I had somebody prone for almost 48 hours, and with the only risk being DTI to the face, which we were able to offset by changing face position and things like that. But that I think was the one thing I also wanted to add, which was a pretty big change in my practice over the course of this.
I mean, this is a chest X-ray, typical chest X-ray probably. I think if you've seen 2 or 3, you will see probably, I mean, 80, 90% of patients who come with COVID pneumonia, they have this type of X-ray where you have interstitial opacities, usually peripheral, usually in lower lobes, but it could be more diffuse. And that would be the presentation of most patients who are admitted to the hospital with hypoxemia. Some of them are, have severe hypoxemia with PF ratio less than 200 or even less than 100. To answer Azim, first of all, ECMO is not available everywhere, and not every center who does ECMO is experienced with medical ECMO. So I think we have to make sure that hospitals that use ECMO for hypoxemic respiratory failure have been, experienced with using ECMO for that purposes for a long time. Otherwise, it's going to cause more harm because of the higher complication rate for ECMO. In my hospital, we have 26 beds potentially for ECMO, and at one point we were using them for 32 patients on ECMO. That means we were using double rooms. We were putting 2 patients in most of the rooms, connecting them to VV ECMO, venous ECMO, most of the time. Few patients required VA ECMO, but mostly VV ECMO. And the mortality rate was low compared to the other studies. So about 10% only, which is very, the survival rate, 90%, which is excellent in patients who have severe hypoxemia. These are the patients who you exhaust all type of mechanical ventilation, proning, everything else you try, nitric oxide, and then they end up in ECMO. Of course, we had to have a selection criteria that exempt patients who have the severe disease that probably will not survive, patients who have other comorbidities, patients with terminal illnesses and so forth, because of the limited resources. But our rate was high. We still have actually. I was rounding yesterday, and we had about 9 patients still on ECMO. Most of them are young, and the problem with these patients who've been on ECMO now for a few weeks, that you don't know what to do with them, and it will create an ethical issue because they're awake, still severely hypoxemic, still requiring ECMO, still 100%. Still requiring mechanical ventilation. How long you keep them on ECMO? They're not candidate for lung transplant. So these are the questions that this ECMO will create in my mind, and we have to address them before we commit patients on ECMO. The question to all of you, and maybe moving related to this topic, the concept of patients self-induced lung injury, and that was described also in the earlier papers, that if you keep the patient on BiPAP, non-invasive ventilation, they will hyperventilate for a long time, and that will create lung injury, ARDS-like pictures. So it's better to intubate them early. And we did that earlier, actually, in my hospital. And then we discovered that actually intubating patients early is not good. It's harmful, and mechanical ventilation early is harmful, going to create all kinds of problems related to ventilator-induced lung injury, DVT, encephalopathy because of the large amount of medication you give, and all kinds of problems. So we moved away from this. But have you seen this phenomena, patients self-induced lung injury, and how do you avoid intubation in these patients who may otherwise would have intubated if they have other diseases, patients who come requiring 100% oxygen and nitric oxide, breathing 34, 36, but still we keep them not intubated, and most of the time it's actually they do well. And maybe you can start with Azim, and then Nahreen, and then Ras.
Sure. I think, in this particular cohort of patients, we definitely figured out ways to optimize, oxygenation and comfort. I think, as has been mentioned, we certainly realized awake proning was of benefit for these patients early on. So we implemented an awake proning protocol. It's odd for a patient to be in a hospital room at the beginning, at the onset, for it just in itself. and it's obviously a little more odd for the patient, especially to be in a hospital room bed on their stomach. So, it takes a little bit of coaching to help them understand why we're doing it, and take some coaching with the respiratory therapy staff and the RN staff to get all that coordinated, but quickly implemented and very efficacious in this specific cohort of patients. I think this type of patient that's so severely hypoxemic, and this concept of sort of self-induced lung injury, it's a tough one for me to conceptualize, because it goes against so much of my training and the experience that I've had in taking care of these patients. And so obviously it's one of those things that you have to analyze on a case-by-case scenario for each patient. When it got to a point where we just felt like our patients were hyperventilating, they were failing, they were fatiguing, these are opportunities where we spoke to family and spoke to the patient and let them know, hey, listen, we've failed the non-invasive means of taking care of you, and now it's time to let the next phase of your therapy to begin. These are patients that had infectious disease consults for every ICU admit. And when it got to the point where we were this hypoxemic, we were offering them trial drugs such as remdesivir. We were talking about anticoagulation. So all of the sort of adjunct treatments that we were able to offer on a trial basis.
Nahri?
Yeah, so I think you sort of beat me to the punch by putting this picture up. So one of the ways, one of the things that we really started to, initially there was such discomfort with using high flow or any kind of non-invasive because of aerosolization. But the more we realized that early intubation is not the answer, the more we had to come up with solutions on how to use non-invasive devices. So high flow was really something that, if you look, there are some studies that were done even before COVID happened about the aerosolization of high flow, and in fact, it's not nearly as bad as we all thought in the beginning. And so high flow became this tool that we used for almost everybody. We would put a surgical mask over the patient, but if they're in a negative pressure room and on their own, then really just placing them on high flow up to 80–90% sometimes, using some non-rebreather for recovery if they needed it when they were moving. But we really heavily relied on high flow nasal cannula, as well as we adopted early on the Cpap helmets, which they look quite ridiculous, but they were quite helpful. They are the helmets that were probably seen. I know there was an article released that University of Chicago was using them as well, but it looks like an astronaut helmet. The patient feels, the big question is always, if you're claustrophobic, does that make things worse for you? And all of our patients really actually enjoyed being on it because it allowed them to see everything. It allowed them to have some freedom from that large, bulky nasal cannula. And that degree of pressure, that 10 centimeters of water was really just such a difference. I think that really speaks to that question of the pseudo ARDS type picture that we would see with some of these patients that were intubated early on and improved within 48 hours, that just that little bit of positive pressure made a very big difference. And in those patients, this was the non-invasive and high flow were incredibly useful to prevent intubation. I know we might talk about this later, but there's also a lot of controversy over things like steroids and timing of steroids or other immunosuppressants, and can that prevent intubation? That was a big question for me because early on in the pandemic, I was not using steroids at all. The initial discussion was it's harmful. As more data came out from prior research in MERS and SARS, and then more recent research out of Wuhan, I started to change my mind about that a little bit on the limited use of steroids, especially in that phase that can hopefully prevent intubation in those patients who are going into that incline of their inflammatory markers and that cytokine storm that we talk about. So those are, I think, were the big strategies that I use to try and prevent intubation as much as possible. And awake proning, as I think somebody mentioned.
I agree. So Ras, what else you have done to avoid intubation? So, I mean, the role of NIV, non-invasive ventilation, how did you implement that? How did you incorporate it in the plan? Because we, like Nahreen and Azim mentioned, in the beginning, we were hesitant to use NIV because of the aerosolization of the virus and the increased risk of exposure. But then we discovered that actually it saves lives and it prevents intubation, and it's better to use it in some patients with even with sometimes we use it with other modalities. How did you incorporate that?
Well, Nareen and Azim have covered most of what we're already doing. We're using a lot more high flow. We have vapotherm at my main center. The only things otherwise that I would add is that it seems like during this crisis, whenever we have been quick to depart from the evidence that we learned in our training, evidence that has been standing for a while, we often find that we're not getting it right. And this is one of the reasons that after several weeks, my colleagues in New Orleans where I train, I used to call them twice a week and say, what's new? What are you guys talking about? And one of the things they were talking about after just 2-3 weeks was doing the basics well. Certainly, I worry about barotrauma in patients who might be taking large tidal volumes on NIPPV or high flow. And generally, it seems like the studies that we did, ARDSNet protocol, would relate also to NIPPV as well as mechanical ventilation. But we're talking about two different populations, and one of them, the one that we're dealing with now in the COVID crisis, was not studied. If you're a subscriber to Dr. John Emil Kinney's normalization fallacy hypothesis, it's difficult to know whether the human body doesn't know what it's doing in a sense with this tachypnea, sometimes very, rather large tidal volumes that these patients are taking. And we just don't know. Ultimately, the risks of mechanical ventilation and doing that early, spending extra days, maybe a week on mechanical ventilation and being sedated, the risk of VTE, the risk of nosocomial infection seems altogether not to justify early intubation. Apart from self-proning, there's not much more that we're doing that hasn't been mentioned.
Did you use pulmonary vasodilators? I mean, we've used nitric oxide. Some other centers use other vasodilators. Have you incorporated that in the management?
Yes, nitric oxide a bit, ibuprostanol a bit as well, and it, for better or for worse, seems to be somewhat provider dependent. Of course, we're the service that gets consulted by, we have COVID patients not just in our medical surgical ICU where we are the primary team, but also in the cardiovascular, the neuro ICUs, and whether ibuprostanol is beneficial, difficult to know. Nitric oxide we actually do subscribe to a bit, and that we've been using as well. But it's just too early to know whether these things are actually improving outcomes. It's wonderful if the next blood gas looks better, or the next 4 blood gases, but as to whether or not that's improving outcomes, very difficult to say for us.
Sure. We actually also use the nitric oxide with high flow nasal cannula in some patients to avoid intubation. So there's all kinds of things that we've done differently, combination of Cpap with high flow, nitric oxide with high flow, to keep the patient saturation above 88%, basically to avoid intubation. And it worked in many patients. So maybe this is a good pivot to the next topic, which is the medical management. And I think Nahreen mentioned the use of steroids. And in my hospital, we started to use steroids early. We used the Decadrone based on the ARDS recommendations, the 20 milligrams BID for 5 days, then 10 milligrams BID for 5 days, early when the patient presents with hypoxemic respiratory failure. Of course, we cannot say that it worked or not. From anecdotes, it looks like it is an effective way in management, preventing intubation, preventing further deterioration of hypoxemia, and so forth. But this disease, as I mentioned, the virus is very smart. It's a systemic disease. It does not only affect the lungs, it affects the coagulation factors. So the COVID-associated coagulopathy is now identified medical illness. It's slightly separate or different than sepsis-associated coagulopathy. Cytokine release storm, which we've seen before in very limited conditions related to chemotherapy or immunotherapy in cancer patients, and HLH. Now we're seeing it more frequently, especially that we're doing trending markers every day on these patients. So how did you manage these two conditions, besides, of course, the incorporation of steroids, Ras and then Nahreen and then Azim?
Excellent question. Steroids, very controversial. Just like Nareem was saying, we decided early on not to use them. What we found actually was that many of our patients were being admitted by hospitalists and nocturnists who were starting steroids. They were looking at bad blood gases and then starting broad spectrum antibiotics and steroids at the same time. Very hard to say that that was improving outcomes in the initial several weeks. So at this point, we really are using steroids only on a case-by-case basis. We're not doing it as a protocol. We actually intentionally had it removed from the order set that we use in our electronic medical record, so that each time that box might be clicked, well, there is no box anymore. It has to be a clinical decision at this point with dosing reviewed by the pharmacist. Were there others that you asked about, Zaya?
The coagulopathy and the cytokine storm release syndrome.
Yes. Well, tocilizumab, the IL-6 inhibitor, is not improved at our center, so we haven't been using it. And thankfully, we've had a modest or moderate, I should say, number of cases. So in that case, yes, we do use steroids in IVIG. In terms of coagulopathy and VTE, which has been one of the most fascinating and deadly aspects of this disease, everyone who can tolerate prophylactic doses of anticoagulants, heparin or enoxaparin, we use it for. We've actually started using intermediate dosing for a lot of our patients. And most of all, having a high index of suspicion for new clot, whether that's a new hypoxemia, much worse than in hours previous, RRT lines clotting off, ECMO catheters having trouble with clots, using bedside ultrasound, and confirming that with dedicated studies later, and often empirically anticoagulating at therapeutic levels patients who are exhibiting any of these signs, just in case we're missing something. But yes, we are increasing our dosing for anticoagulants.
Nahreen?
Yeah, I would say the trend really went towards more intermediate or therapeutic dosing of anticoagulation, with exceptions being patients who have contraindications, especially those patients that made it to the ICU that sort of kind of put them in a category where they were sicker, higher risk, and for the most part, all of those patients were placed on therapeutic anticoagulation unless there was a concern that they were high risk for bleeding. Now, that, of course, the next question that we all ask is, well, what was the risk of bleeding, and what were the complications? I think nationwide the reports are something like 3% on full dose anticoagulation. I would say, in the 2 months of practice, I probably had a handful of people who did bleed significantly. It was usually a GI related bleed or a line related bleed, something like that. But there were cases of devastating neurologic bleeds as well. Some of these patients. And so I think, yes, the risk is there, and I think we have to be extremely cautious, but for the most part in our practice, we were using therapeutic and intermediate, and in those that were extremely high risk, at the very minimum, they were on the standard prophylactic dosing. We tried to use enoxaparin as much as possible, obviously with renal failure being such a huge complication in these patients and something that is often not talked about as much. We ended up having to use heparin in many patients, and I think that's where things got a bit tricky, because heparin, of course, is always you know, a little troublesome with trying to stay in that narrow window of your PTT. And then, so in which case we started using anti-10A levels a little more frequently as well.
So, I mean, just to be on the same page, when you say intermediate dose heparin, that means you're trying to keep PTT between 40 to 60 without bolus. Is that fair to say?
Yeah, so there was a, I can share my screen if that's helpful. But basically, yes, we would change the PTT goal or change the dosing of the enoxaparin in order to kind of reach the, and actually not the PTT goal even. It was pretty standard that unfractionated heparin, therapeutically, we did our normal PTT range. For intermediate, it was still, it was 7,500 Q8 is what we were using. So not parenteral, but just a higher dose of your sub-Q heparin.
Oh,
Therapeutic, we stayed with our normal PTT goals, staying within 60 to 80. But our intermediate was like 7,500 Q8 for heparin, and then for low molecular weight, I believe it was half a mg per kg Q12, I think.
yeah,
that's correct.
Heparin drip for intermediate dose, and for those patients who have D dimers more than 6 times the normal, which is in our hospital more than 3, and also for sick, which is sepsis-induced coagulation score more than 4. Were you using these scores and values to guide your intermediate dose of heparin, Azim?
Yes, that's exactly right. We were dosing anticoagulation based on D dimers. You know, the SIC score, I think, is provider dependent. It is something that I do factor in, but according to our institution protocol, we were using D dimer as our guide. So, you know, what factor above normal, and just like you said, 6 factor higher with your D dimer elevation essentially led to therapeutic dosing or clinical suspicion. Just like Ross said, you know, if you had this new onset of sudden hypoxemia or hemodynamic change, you have your portable ultrasound there, and you're suspecting something else related to venous thromboembolism, then we were anticoagulating them regardless of their D dimer. But that's the standard cutoff we used, was 6-fold higher.
For the cytokine release syndrome, I mean, we've used, like Ross has mentioned, steroids, of course, and tocilizumab. Have you used anything else? Although this is done without evidence-based. I mean, we used it because it makes sense. So the virus, of course, attacks epithelial cells in the lungs and the airways. It exhausts T cells. It can cause the macrophage to release interleukin-6, which we measure actually in not every patient, but most of the patients, I would say, when they are admitted with severe hypoxemia and other inflammatory factors. So it makes sense to give something that is anti-interleukin-6, and that's the idea behind using tocilizumab. Have you used anything else? Is there any developing evidence about using any of that support its use in the literature?
We haven't used anything else. I will say that we have used CRRT, renal replacement therapy, in these patients almost universally, it seems, once they're intubated. And, you know, not only for maybe removing some of these inflammatory markers, but for volume, because of the tremendous amount of volume these patients get from sedation and analgesia and the medications. So, you know, supportively, we have been using renal replacement in that capacity, but specifically for the sort of cytokine storm aspect of it, nothing beyond what's already mentioned.
Okay, so maybe we can move to the last part of the discussion, which is related to dealing with limited resources. And, you know, we work together Nahreen and Azim, and hopefully with Ras at one point in countries like Sierra Leone, Yemen, Gaza, Bangladesh, Syria, and other places where there's limited resources. So even ventilators are not available. The country of Sierra Leone, where we had medical mission, Azim has 1 ventilator for 8 million people. In areas, I mean, my hospital in Chicago, Christ Advocate, has more ventilator than Syria and Gaza combined. But we still have limited supplies and resources in the United States. So how did you deal with the limited resources, whether it's the PPEs or your hospital dealt with this, or ventilators, or ICU room, or nursing, or medications for sedation, things like that? Anyone can try.
Sure, I'll start. Oh, go ahead, Nahreen.
No, go ahead, Azim, go ahead.
Well, what I would say is these were issues, I think, because the PPE shortage was so prevalent at the onset of all this, because we had the benefit of what happened in, just outside of Seattle and what happened in New York City, we were able to take that time advantage and prepare plans in place sooner than other people might have. With that, I think tracking what access to supplies we had, and what we would get were updates sort of on what our N95 regular size mask was, what our supply was the N95 small, what supplies of masks otherwise do we have, what is our ventilator usage, what is our ICU usage, and these were sort of stats that we'd get every day to keep us updated on what it is that we needed to protect ourselves, to protect our patients, to protect the staff, and what it is that we needed to take care of our patients. When it comes down to preparedness, I think it was very shocking for us to realize that we were going to have to come up with innovative ways on conservation. At my institution, we obviously were figuring out ways of how to reuse the N95 respirator masks, and we were, implemented a hydrogen peroxide, sanitization process for that. Was I reusing my N95 for a period of a week? Yes. This is such a novel thing for me to conceptualize beyond when we were traveling to these lower resource settings. So to have to experience that here was certainly strange. Now, when it came down to the statistics we received about what our supplies were, that also included medication. So what was our benzodiazepine supply? What was our oxycodone supply? What was our propofol, Versed, fentanyl IV supply? We were quickly supplementing a lot of those medications through the enteral tube, so that we could potentially minimize the infusion rates. But I think just as it was in other places, we were having to figure out innovative ways to conserve, to make sure that we were still offering high quality care in that setting of shortages.
Sure. Nahreen, Ras?
Yeah, I fully agree. I think a little bit of a different take on it is, so I trained in New York City for fellowship, which gave me a unique experience in that while in Philadelphia was nothing like New York City, I was hearing directly from their experiences as well. And it was devastating to hear that one of the biggest things, I think, as you mentioned, the ventilator shortage across the world, across the ocean is very different, right? I'll give you an example of when I was in Ethiopia and walking through the emergency room and trying to figure out, of the 2 open beds in the ICU and of the 7 patients waiting for those 2 beds, how do we pick who gets those 2 ventilators? That was a problem I thought was just limited to being in Africa or being in Bangladesh when I'm practicing there. But as it turns out, that was a real problem, that there was a ventilator shortage, and those decisions and having to make those decisions on what to do with limited resources was an extremely emotionally taxing thing for our colleagues in New York City who really had to make those decisions. And I think it really pushed me to think a lot more about the risk benefit of the interventions that we provide. So just kind of talking about, really thinking about how I use my brain when I'm in a limited resource and shifting that mentality to now in the US. And even outside of the pandemic, if the risk of putting somebody on mechanical ventilator in a setting of a very poor prognosis, I think really talking about those matters earlier on, it really pushed a lot of us to deal with utilizing palliative care on the earlier side. So I think that was really a big response to this concept of limited resources, that, not saying that, hey, you're sick, we're not going to treat you, but if you're sick and your prognosis is poor, and really talking about the utilization of resources for the greater good, a really challenging topic, right? I mean, ethically and otherwise, that I think a lot of us really struggle with, even those of us that practice abroad, because when we practice in the US, we practice in a resource-rich scenario. And so we're not used to utilizing that mentality here. And I think that was a really, that was very jarring for me to all of a sudden change my mindset back to what it's like to practice in Africa or South Asia and other areas that we've been in. One of the other things, I agree with Azim, there was a lot of innovation regarding sedation and how to utilize PO and enteral medications. And that was a really big lift on the side of the pharmacy departments. And, Penn has an extremely strong pharmacy department. And so they were great in just coming up with solutions and innovations on how to utilize other drugs, when it came to pharmaceutical shortages. And then, of course, just in general, the N95 mask shortage, that was a really stressful situation for a lot of people. And finally, once I think every hospital came up with their disinfectant protocol, which we're using the same thing as you guys, Azim, and even now. So, that to me was a really eye-opening experience for even somebody who works in resource-limited areas.
Do you mean that practicing in low resources countries help you managing your patients in high resources countries?
Absolutely, absolutely. I've always thought that, and vice versa, right? We always learn so much from low resource settings because that's true. Think about what came out of being in a low resource situation right now, right? The innovation, the ingenuity, the collaboration, that's happening nonstop in low resource areas because they have to. That's a matter of survival all the time, not just in a pandemic. So I think that to me really said, okay, look, I feel a little more prepared for this because I've seen it elsewhere. I know what it takes to kind of overcome those low resources. Means that you have to utilize what you have and get creative and innovative and really push for people to maximize what's available.
Raz, what do you think?
Excellent. Yes, excellent all around. Recycling PPE, excellent idea. I very much agree with Noreen's comment. It's interesting how more than ever in my career, I had families coming to me and saying, our elderly grandparent, loved one, looks like they're going into worsening respiratory failure. We've talked as a family and we don't want them on the ventilator at all. It was almost like they were sort of taking information that they'd heard in the media and, decisions that we struggle as doctors to get them to arrive at, or to we partner with our patients, we share decision making. But many of them were coming to us and saying, hey, listen, we don't want this for our loved ones. So it was very interesting to see how even they seem to respond to, reports of resource limitations.
Which maybe bring me to the last point, and we're ahead of time, but I think this is a very important topic. But by the way, we have a webinar next week about managing patients with COVID in low resources countries, when you don't have maybe ventilators, when you don't have high flow oxygen. We talked about high flow nasal cannula or oxygen here as if it's available everywhere. It's not. You consume about 7,000 liters for one patient of oxygen if you use 40 liters per minute. In many hospitals in the rest of the world, you cannot afford to use that amount of oxygen for one patient. So imagine yourself working in a hospital that you do not have an ICU, or maybe very limited beds of ICU. You have maybe 1 or 2 ventilators. You don't have high flow oxygen. You may have oxygen that will be enough for 3 or 4 patients for one day. What do you do? I think these are the topic we're going to be discussing next week. The last question is the future of management of COVID patients. here in this setting in the US. This is the first wave, as everyone is predicting. The second wave may be even worse, as many authorities in public health and infectious disease expect. That could be in the fall, could be in the winter, could be before that. We don't know. What do you think? What should we be doing from now, preparing for the second wave, as physicians, as intensivists, as pulmonologists, as people who have influence in our medical communities? What should we be doing to do things better than what we have done in the first wave?
One thing I would like to see is optimization of testing. We lost an awful lot of PPE to using it for patients who didn't need it. Initially at our major center, it was taking 3 to 6 days to get test results back, during which time everybody was using an N95, a mask, face shield for those patients, and there was a lot of waste. So I hope that we have our testing ready to go. And a lot of what we've already done, isolating the patients early, cohorting the COVID patients, making sure that we get the basics right. Hopefully, the evidence will bear out some treatments that we can be more confident in, and really just consolidating everything we've learned over the last few months and having it ready to go.
Yeah, I think one of the biggest things I worry about is the comfort levels that we're seeing now of the public, that as things get, as things sort of relax and the restrictions relax, that people sort of might start to feel, and we are, I'm sure, feeling that on the healthcare side in hospitals as well, that okay, things are going to be okay, it's going to be fine. There's no need to worry as things slow down. But I think really, yeah, I think really continuing to wear the masks and the precautions standard precautions that we're taking at work, I think are really important. I think really focusing on some of the simple things like hand hygiene and really pushing the public health campaign on how people need to remain safe, and just common sense thinking as we move forward, and not letting our guard down. I think that's probably the biggest thing to me, is that in the beginning of this, I remember I was coming back from Bangladesh at the end of February, and COVID had just started to really make the news in a really big way. And I thought, oh, there's no way that's going to happen to this extent. I never dreamed it was going to happen like this. I think that was the biggest mistake many of us made, that we thought it can't happen here, right? And I think that and it can't happen to this extent, and that even if it did, that we would be so prepared. I think that is where the mistake was in the beginning. And I think now that we've seen what this looks like, I think assuming it's going to be easier in the future is a big mistake. I think really being as prepared as possible, which was what I felt we weren't in the beginning. And now that we have these ways to strategize and prepare hospitals and the community, I think doing that earlier on, and paying close attention to the trends. One of the big things that I'll mention that in Philadelphia, the hospitals here did really well, was a daily communication email to all of the healthcare workers, and specific committee meetings that met on a very frequent basis. This allowed that any new information that came in led to changes and shifts in the way the hospital structure was. I think that was probably one of the biggest things. Just communication in general, transparent communication to the healthcare facilities and healthcare workers, as well as the public. And I think keeping as prepared as possible is probably the best advice.
If that was a cue to me, that's perfect. I think testing is a huge key to the future. Here in Charlotte, it's so interesting to see, just like Nahreen said, we're getting daily updates, including statistics about what our percent positive is, what number of testing we're getting done. And in the state, as I'm sure you guys are experiencing the same thing, the number of tests per state and per city is rapidly increasing. And I think that's the key to our sort of optimization of COVID care in the future, identifying who's ill, identifying who needs to be taken care of at home versus in the hospital. We have access to virtual hospital for patients that are not ill enough that they require inpatient care, but yet are still taken care of virtually and supplemented by paramedicine. what we've identified are areas where we have high prevalence of the disease, including in vulnerable populations and close-knit communities. We have a big spike in our numbers in the Hispanic population, which is something that needs to get identified. And without testing sufficient for the general population, you can't identify these clusters. You can't trace their contacts and potentially limit further exposures. And so I think that's important in moving forward into the future. The public education aspect of this is so tremendous. There's so much doubt. There's so much skepticism now about the information that is disseminated from even credible sources now. And the social media aspect of this is so tremendous. We're living in this age where social media is a big source of information for people that don't have the education to really understand what the headlines mean. I read a paper just the other day where the headline said, you really don't need to wear a mask anymore. And when you read into the body of the actual article, it's saying that the communities where masks were used had the least prevalence of the disease and the least spread of the disease. Meanwhile, the headline still said, such and such body does not recommend wearing a mask. And that's really what people are going to see. They're going to see the headline. They're going to, forward and disseminate this little portion of it and not really read into the detail. I'm not an epidemiologist, but it's forced so many of us to become such individuals because we're being asked from our peers and our colleagues some of these questions, and it's difficult to do so.
One of the things I just wanted to mention really quick that Azim, you sort of hinted on very, very nicely is the inequities that we've seen with COVID really opened up, I think, the healthcare inequities across the board, right? COVID just sort of uncovered a lot of what we're seeing with healthcare inequity in the US. It's not just something that we see, in our global population. It's really, really been such a huge problem. And I think really focusing on why that's happening and how to target that is incredibly important. An incredibly important lesson that we're learning from this is how can we start to really support the safety net hospitals that are in communities that are marginalized and underserved, and making sure that we support that, because certainly we're seeing that communities in certain areas are much more affected. The Black community, the Hispanic community, people of color were extremely affected by COVID, much more so. And I think really understanding the social determinants of that are really important, and the systemic determinants of that are really important, because we cannot continue to let that happen. And I think that's something that's been really eye-opening to see as well. And I know, Zahir, you've seen that as well in Chicago firsthand.
Oh, definitely. I think that's a good end of this program. We are in the midst of protests and demonstrations for the murder of George Floyd, which is basically a symptom of a much bigger disease, which is related to systematic racism and disparity, healthcare, economic, socioeconomic, education disparity that we are seeing in this country. I cover two hospitals. One of them is a safety net hospital called St. Anthony's in the west side of Chicago. And they lost half of their nurses. They got infected with COVID, and they could not find a nurse to cover the ICU. So they struggled to find nurses, while the other hospital has abundance of everything. The African American community and the Latino community were hit hard with COVID because of the food desert that is causing more obesity, hypertension, diabetes that are associated with increased morbidity and mortality with COVID. So healthcare disparity is a real issue. We have to address them. In MedGlobal, we supported some of the safety net hospitals with medical supplies, with PPEs, with even incentive for nurses in the ICU, with PCR machines. The Navajo Nation, the Native Indian or Native Americans actually, who were hit really hard in this epidemic, and per capita, they're hit more than any other state. and we are also supporting the Navajo Nation with PPEs and medical supplies. This is a picture that Dr. Nahreen Ahmed is training Yemeni physicians in the last medical mission to Yemen, Hadramaut. This is something that MedGlobal has been doing for the past 3 years, where we have doctors like Azim, Nahreen, Ras going to areas that have low resources or actual sometimes in the middle of war, and making these communities more resilient by providing training, technology, innovations, medical supplies, and other resources. And hopefully after the travel restrictions are lifted, we will resume doing that. But in the last 3 months, we've been sending a lot of PPEs to areas that are in much need: Gaza, Bangladesh, Pakistan, Syria, Yemen, Sudan, Ecuador, Colombia, because this is something that we can do without traveling. And I invite everyone to join us in MedGlobal, not only to attend these webinars, but also to volunteer in our medical missions, spread the word about what we do, and also donate to the organization. That your donation will be translated into saving lives. Thank you very much. This is very helpful. Thank you, Denise, for organizing this. Would you like to end with any announcement, Denise?
Thank you so much, Dr. Sadul. Thank you so much, Dr. Rose Hoffman, Dr. Nahreen Ahmed, and Dr. Azim Alahi for joining us and sharing all your knowledge with us. As Dr. Sadul mentioned, I know that COVID-19 has impacted us in different ways, and learning what we are doing in the United States led us to reflect what can we do to help low-resource countries. To address that, we are having a webinar on COVID-19 diagnosis and management in low-resource countries next week. So I really encourage you to join us next week to address this topic as well. Dr. Sadul and Dr. Nahreen will be joining us in this webinar, along with Dr. Riley Jones as well. Thank you everyone to join, and hope to see you next week as well. Thank you.
Thanks very much.
Thank you.